ophthalmology patients. Henceforth, we'll call it TNT. Let's dive in. TNT number 1. History, history, history. Why is it important? They say if you look, you will find. A good history keys you in on what to look out for. The best way I can emphasize this is with an example. In December of 2019, we were asked to see this 12-year-old Cambodian girl for a possible left optic nerve glioma. On the left, you can see she has a non-axial proptosis of her left eye. Her MRI scan is on the right. Just looking at this, we may all be happy to say glioma. But when you take her history, there are multiple red flags everywhere. This busy slide is not meant to be read, but to illustrate that it takes time and patience to get a good history. It took me an hour or more to get this to an interpreter. Unfortunately, there is no shortcut. But the time is well spent. We learned that she has been dealing with this issue for 18 months, has been to 2 countries, Vietnam and Thailand, to try to resolve it. Now she's here in Singapore. I think we need to take the time required to sort it out for her. To summarize, over the last 18 months, she has had multiple lesions in the brain and abdomen which seem to improve when she takes prednisolone. This is a multi-systemic problem. The differentials we could think of were lymphoma, inflammatory conditions like sarcoidosis, or infective things like TB. Sarcoidosis was really at the top of my differentials. So I was looking for uveitis, lupus pernio, or any other sign of inflammation. She was blind in the left eye with a fixed and dilated pupil. That left eye had mutton fat KPs, slightly unusual for glioma to give rise to ocular inflammation. More interestingly, in her only seeing right eye, she also had fine KPs and anterior chamber activity. Posteriorly in that eye, she had some vasculitis over the superior arcade. She was admitted for workup by the oncologist and rheumatologist with a working diagnosis of sarcoidosis. They were still deciding regarding biopsy of the optic nerve mass, but decided to return to Cambodia in the interim. I have not seen them since the pandemic started, but I hope you get my point on how important a good history is. TNT number 2, have all your equipment readily available. There is nothing worse than asking an already crying and distressed child to wait. These no-peeking eye patches are particularly useful. I bought a whole roll of 100 for US $10, much cheaper than the amblyopia patches. I have the blue one with the star, and after the test, I stick it on the t-shirt and tell them they are my star patient. Sometimes mommy gets one too. TNT number 3, use the parents to help you. As an MO, we always did not like Pete's clinic. We joked that we had to treat the parent and the child, 2 for the price of 1. Well, since they are there, use them to help you. And they actually are really good. For example, if I'm doing indirect ophthalmoscopy, I will turn to mom first and say, "Come, mommy, let's see if you can see the movie in my hat." Mommy is usually very helpful and will hallucinate for me and say, "Oh yes, I can see baby shark." Then we'll move on to the child. It may take a little longer, but it sure beats dealing with a crying, struggling child. If I have to put on an eye patch, we have mommy wearing one first, and she puts one on for the child. I think you get the picture. TNT number 4, honesty is the best policy. If you tell the child they will get a reward for doing a task, you have to follow through. If you really cannot examine the child, tell the parent, "Sorry, but perhaps it's better to come back again and let me review." Meanwhile, with the availability of handphones, I always ask mom and dad to take a picture or a video for me of the issue at hand. TNT number 5, know when to quit. Children in the neuro ophthalmology clinic have been through more than you and I have. Surgery, needles, radiation, chemotherapy. Their parents are also constantly fatigued with worry, juggling work and other children, spouse, financial problems. Sometimes, if things are not working out, it may be better to just quit and try another day. Know when is too much for the child. TNT number 6, visual acuity is key. Visual acuity is of utmost importance to the neuro-ophthalmologist. We use that in conjunction with other modalities of visual function to determine which child needs treatment, sometimes with potent drugs with severe life-threatening side effects. In children, where it may be impossible to do visual fields or color vision, acuity becomes our only modality to make this decision. Hence, a good understanding of how we test and what we consider deterioration is essential. Always recheck the acuity yourself when in doubt. Use a standardized method, and trend is more important than a single reading. This is just a copy of the telerecord sheets we use in KK. It is a nice way to trend the acuity and to show parents as well. I recommend this article by Bailey and Love as it shows us the years of research that has gone into what we take for granted every day. In order to get accurate, repeatable, and reliable acuity, we need to standardize the method we use. Essentially, this requires us to use the same chart design, the same optotype, and standardize our testing protocol. There are many chart designs, from the standard Snellen on the left to the Bailey and Love used in the ETDRS in the middle, to the electronic version, which is now almost the standard in any pediatric ophthalmology clinic. I use the electronic visual acuity chart, and I will take note if I use a line or singles with crowding bars. The important thing is to standardize which one you use for your patient. In large clinics with many different rooms and different optometrists, I usually like to do the acuity myself in my same clinic room so that I know exactly how the child is doing. In addition to chart design, also use the same optotype, but try to progress to optotypes that give a more accurate and reliable assessment of visual acuity as the child grows. For example, you're seeing an infant and using FPL and plotting his acuity on the charts I showed you earlier. As the child gets older, I will give mom the HOTV optotypes and ask mom to teach the child to match. When I see the child again, if he can match HOTV, I will use HOTV acuity. In terms of accuracy, Sloan, British Standard, and Snellen is better than Lear, which is better than HOTV. This means that if we test the child, let's say with Lear and HOTV, the Lear visual acuity will be poorer than on HOTV testing. Another way of putting it is that HOTV overestimates the acuity. Allen and Kay pictures are the least accurate and usually overestimates acuity and gives better visual acuity than you would get if you use the Snellen. This slide just shows you the different optotypes available. This is just my personal preference, but everyone is different. We have covered chart design, optotype, and now testing protocol. How you test is important. I like to encourage guessing, allow for corrections, forgive errors, and use the arrow or get my nurse to help. This is not the correct way, it is just my way. You need to just standardize the way you check and realize that if you do what I do, you are pushing the patient, and the acuity you get may be better than the one your nurse did outside because she had 10 more crying children waiting and did not have the time to edge the patient on. TNT number 7. I like to use the trans illuminator to check for anisocoria. The light beam from that spreads out and allows me to catch both pupils in the same beam. I cannot do that with the direct ophthalmoscope. Another trick I like is to look for anisocoria with a red reflex, especially if the child will not let me get close. TNT number 8. Give the child a task to do as you examine him. It takes their mind off being frightened and makes the session like a game. You need to know the pictures in detail yourself. I like the car on the Lang fixation cube. Ask them, what color is the car? How many wheels can you see? What is the color of the wheel cap? Can you see the car number plate? And is there somebody driving the car? My favorite is, why is there nobody driving the car? Because you have to study hard and then buy this car for your mommy, understand? For the policeman, ask what color is his uniform? How many buttons does he have on his shirt? Does his shoes have shoelaces? Is he wearing gloves? You get the gist of it. TNT number 9 is on the importance of confrontation visual field. For me, the confrontation visual field serves two important purposes: an aptitude test and as a general overview of the type of defect in the child. During my confrontation visual field testing, I will determine if the child can cooperate. If so, can they do a Humphrey or Goldman? If the child cannot cooperate, I know that my field and any other field test I send the child for will not yield any useful information. It also gives me a general overview of the defect I am likely to find, and this should correlate with the Goldman or Humphrey field. Your method of performing confrontation visual fields depends on the child. In some infants, there is just no way to assess the fields. In pre-verbal children, we can assess grossly for a field defect by testing their response to objects that come in from the side as the child is looking straight ahead. The setup is as in the picture. The child sits with the parent. If you have to do monocular testing, I usually like to patch the child. Your nurse sits in front to attract the child's attention, and the object is brought in from the side. In older children, visual fields are tested much like that in adults, but the way we explain it to them is different. I usually tell them we're going to play a game. They have to look at my eye, for if they look at the side at the fingers, we have to stop playing. What I tell my residents is that the child will only give two responses. Either he sees your fingers and he will respond, or he does not and he will not say anything. So don't wait for them to say, I cannot see. Again, compare the responses in the different quadrants. If it is slower, suspect the problem and test again. Just a tip on how to correlate your finding on confrontation field testing to the HVF. In your initial assessment, ask the child to look at the bridge of your nose. If the part they cannot see is within your face, then the defect is usually in the central 15 to 20 degrees. I find this most useful for central defects that you get in optic neuritis or retinal disorders like PAM or AMN, both of which are rare conditions. Another tip, but I must emphasize that this is a rare cause of face turn, and please look for other causes first. However, in children with a brain insult early in life, usually in the first 1 to 2 years, they develop a face turn to the side of the field defect. I have only one child who has this, and he had a hemispherectomy for intractable seizures at age 1. I have not been able to find the pathophysiology for this condition. TNT number 10, assessing saccades. In my clinic, I am usually interested to test saccades when I suspect oculomotor apraxia, be it congenital or acquired. This can be done by looking at the quick phases of the optokinetic nystagmus or vestibular nystagmus. To produce and observe vestibular nystagmus, either hold the infant vertically if there is good neck control, as in the picture on top from Taylor and Hoyt's book, or horizontally if neck control is poor. Spin the infant in one direction, maintaining eye contact, and then the other, and observe. In the older child, you can do a head thrust to look at the vestibular response. We can also use the optokinetic system to assess saccades. Hold the drum or tape in front of the infant and rotate it in one direction and then the other, vertically and then horizontally. TNT number 11, generating and observing optokinetic nystagmus. First, we must understand that to generate the optokinetic nystagmus, we need reasonable vision and normal eye movements. I usually use the OKN drum in 3 settings. First, in a child who has a completely normal eye exam and I suspect appears blind because he has a problem with initiating saccades, like in congenital oculomotor apraxia. Second, in a child or person with suspected functional visual loss. And third, in a child with idiopathic infantile nystagmus, looking for a reversal of OKN and to estimate the visual acuity. The acuity is estimated by rotating the drum vertically, and if you see nystagmus, acuity is normally 660 or better. I used to have difficulty appreciating the nystagmus in infants, but now I realize that the attention span in infants and kids are shorter than in adults. Hence, you may not see the sustained optokinetic nystagmus as in adults. Get the child's attention on the drum by tapping it loudly or making some interesting noises as you sit behind the drum, and watch carefully for usually 2 to 4 beats. test horizontally as well as vertically. In younger children, I find the OKN with the pictures more useful, but usually have both and test with both. TNT number 12. In infants and young children, it may be necessary to patch either eye to assess ductions, particularly in the context of differentiating esotropia with cross-fixation from an abduction deficit. They will usually be crying whatever you do. The key is to get the patch on and not let the child peel it off. TNT number 13. I like to test near vision myself and get an idea of the problems the child has reading. Usually I observe the child looking at a book, doing some writing, or sometimes playing games on the handphone. Many books mention that accommodation in children with neurological problems is poor, but I have not experienced that and have not yet prescribed bifocals to children. Besides problems with accommodation, we look for reading problems due to visual field defects, especially left homonymous field defects, or saccadic problems, motility problems, like downgaze palsies. TNT number 14. Testing visual acuity and looking for abnormal head posture in a child with infantile idiopathic nystagmus. Always do not occlude the fellow eye when testing for visual acuity, as occlusion may manifest the latent nystagmus and degrade the vision. In addition, allow the child to turn the head and put the eye in the null position for best visual acuity. If latent nystagmus is present, suspect that there may be some amblyopia if the nystagmus is asymmetrical. The amblyopic eye is usually the one where the latent nystagmus is most pronounced. To bring out the abnormal head posture, get the child to read optotypes as you reduce the size of them. To get best vision, the child will turn his head and put his eye in the null point, thereby getting the best visual acuity. Last but not least, TNT number 15, color vision. I find HRR sometimes easier for young kids as they have only to recognize 3 shapes. I may get mom to start teaching the child the shapes early and get them familiar with matching the shapes. In children, we make do with what we can get. I may prompt the child by asking them to point to where the circle is. Just record how you did it for consistency. Usually, I just record down the number of screening plates they got correct. So the denominator is 10. I hope this has been helpful. Thank you for your kind attention.
Thank you. Thank you, Suen, for your very enlightening talk. I really enjoyed it. So for the next segment, I'd like to invite Clinical Associate Prof. Sharon Toh. Sharon is a senior consultant at our Singapore National Eye Centre in the Neuro Ophthalmology Department, and she will give us a short segment on the use of Botox in neuro ophthalmology. Sharon, please.
Thank you, Jing Liang. I have no financial interest to declare. So in neuro-ophthalmology, we give Botox for facial spasms, namely hemifacial spasm and blepharospasm. So starting with hemifacial spasm, it's an involuntary paroxysmal burst of unilateral tonic or clonic contractions of muscles innervated by the facial nerve. Its etiology is said to be due to pulsatile compression of the facial nerve as it exits the brainstem by an aberrant blood vessel. However, in less than 1% of cases, it is caused by other compressive lesions such as a tumor, which is why we always ask patients to go for an MRI when we first see them presenting with a hemifacial spasm. In terms of treatment, when patients ask us, is there a cure? We say yes, there is. And the cure is surgical microvascular decompression of the nerve at the root entry zone where the offending vessel is moved away and a Teflon pad placed over the nerve. The success rate is said to be about 90%. However, there are some morbidities associated with it. So depending on the culture you come from, some people will go for it. However, in Singapore, we find that our population is quite risk adverse, and usually they will opt for other modalities of treatment. So medical therapy, for example, carbamazepine and gabapentin, have proven to be not very effective, and therefore Botox intramuscular injections is really the mainstay of treatment, and this is effective and controls the symptoms. So the initial effect after the Botox injection is seen within 3 days. It peaks at about 1 to 2 weeks after the injection. The duration is generally from 12 to 14 weeks. Complications are minor bruising, dry eyes, ptosis, sometimes leg ophthalmos, ectropion, facial asymmetry. Having said that, it's really quite unusual. The most common dry eyes, and very rarely diplopia has been reported. So this is a video of a patient with hemifacial spasm. On the right side. And after Botox, you can see alleviation of most of the spasm, just a little bit of twitching of the right lip. Another patient with right hemifacial spasm, this time it's more severe. She's asked to open her eyes. She's unable to. Post Botox. She's asked to close and open her eyes. Moving on to blepharospasm. This is an involuntary closure of the eyelids due to contraction of the orbicularis oculi. Some cases are associated with Parkinson's disease, progressive supranuclear palsy, strokes, MS, multiple sclerosis. However, the majority are benign essential blepharospasm, and this occurs in isolation without other neurologic or ocular disease. And the diagnosis is made on the clinical presentation and the patient symptomatology, and neuroimaging is not necessary. The female patients are usually females over the age of 50. The condition is bilateral, and it tends to worsen in severity and frequency over time. It's a very disabling condition. Many patients are unable to read, watch TV, or drive. They become depressed, become occupationally disabled, and some are actually functionally blind. We manage them by lubricants and lid hygiene, although this is only improves them by about 5 to 10% at most. Oral medications are also not very effective, although we do try things like clonazepam with some side effects such as drowsiness. And so Botox or botulinum toxin type A is again the mainstay of therapy. Surgery is possible, and this is reserved only for patients who have disabling benign essential blepharospasm despite Botox. And this consists of removal of part of the orbicularis oculi muscle. Following surgery, recurrences are still frequent, and patients still require Botox post-surgery, although there is some improvement overall. The location of Botox injection points are shown here. So for example, patients with hemifacial spasm who have involvement of the eyelids and the brow area will have injection points similar to those of patients with blepharospasm, except it's unilateral. And then when it involves the cheek, as you can see on the left side of this patient, of this drawing, you can see the points where it may be given. Botox is tailored according to where the muscle is twitching, and everybody is different for both hemifacial spasm and blepharospasm, but particularly hemifacial spasm. So this is a patient with benign essential blepharospasm. You can see that how it can be a very debilitating condition. And she's telling us she can hardly open her eyes. And this is her post-Botox, and she's so happy. She's a changed person. You can hardly recognize her. She's changed her hair. And she's asked to close her eyes, open her eyes, and she can do this easily. This is another patient with benign essential blepharospasm, and this is associated with apraxia of eyelid opening, which can be associated, which is makes it even worse. So she can't open her eyes at all. She has to use a trick of putting her fingers on her lower lids, and then her eyes will open. Post-Botox. There is improvement. She's able to open her eyes. So although effect is temporary, Botox is able to improve the vision, function, and quality of life of patients with hemifacial spasm and blepharospasm. This is from a patient of mine with blepharospasm. She says, "Thank you for everything. Thank you for helping me to regain my confidence, to meeting people. Before the treatment for my facial spasm, I used to stay away from people. Thanks and many thanks." So this is just to illustrate to you how Botox can help patients with spasm conditions, hemifacial spasms, blepharospasms, particularly blepharospasms where patients are so debilitated. And following this, I would like to acknowledge Dr. Lu Jingliang, who contributed videos, and these are my references. Thank you. And now there will be a short video from Elegant about how Botox works.
The heritage of allergan and botulinum toxin type A spans 30 years. But how does Botox work? During normal muscle contraction, acetylcholine is released from synaptic vesicles in the presynaptic motor nerve terminal. The snare complex, involving the proteins syntaxin, VAMP, synaptobrevin, and SNAP25, allows vesicles to fuse with the nerve membrane. Acetylcholine is then released and diffuses across the synaptic cleft before attaching to its receptor on the postsynaptic membrane of the muscle cell to enable contraction. After injection, the fluid environment causes the interactions between the approximately 150 kilodalton core and the accessory proteins to disassociate over time. The binding domain of the Botox core molecule is the C-terminal portion of the heavy chain, which interacts with the receptor complex on the nerve terminal to form a multi-receptor complex. The Botox core molecule enters the nerve cell by the process of receptor-mediated endocytosis. The toxin is now contained in a membranous vesicle inside the nerve cell. The light chain is then released into the neuronal cytoplasm, where it cleaves its snare protein target, SNAP25, to prevent the docking of the synaptic vesicle. Disruption to the snare complex prevents synaptic vesicular fusion and neurotransmitter release. In motor neurons, Botox decreases acetylcholine release to reduce or prevent muscle contraction.
So we come to the last part of our session today, and this is going to be by Prof. Umar, and he's going to talk about eye movements made easy. and he's going to talk also about dim sum. So over to you, Prof. Umapathy. Thank you so much.
I can't seem to be able to share screen. This I'm unable to share screen. Okay, now okay. Okay, good. So I've been given about 25 minutes to talk about eye movements. So I was very wary of giving you indigestion. So I decided to become a dim sum waiter. So as you know, when you go to a dim sum restaurant, somebody like this will come to you with plates all stacked up nicely in a tray, right? And then you just choose what you want to eat, how much you want to eat, how slow or how fast you want to eat, and when you want to stop. Okay, so with that spirit in mind, I'm going to put this up for you guys. And you choose now what you want to eat. I would suggest you try to choose topics that you find normally quite indigestible, so that let's see whether I can make it more digestible for you all. And then based on what you have chosen, we will have the talk. And then exactly at 25 minutes, we all have to do better things on a Saturday afternoon, right? So we'll stop exactly at 25 minutes because then by then we should be seated. Okay, Ruben, you want to put up the poll?
Sure. Thank you, Dr. Uma. So on your screens now, you would see the 10 different types of dim sum that actually Dr. Uma is allowing us to choose from. So any of the 10 you can choose, and we will go through the choices polled by the audience in order of popularity. So
you notice the first three, I kind of put a bit of a bias on my own favorite dim sums, mostly plant-based, but some of them are not so much plant-based, but mostly on the top corner is the top most are my favorite ones. But generally, I when I go to except for egg tarts, I don't like egg tarts. I go for everything else. Okay, so you can choose anything actually, based on what you think is it's something that's difficult. And for basic fundamentals, I think I've sent out different sort of links. Unfortunately, I understand that some of the links are not working because they've been they have a limit on the number of downloads. So I've sent out another link. So that will give you the basic foundational aspects so that we can just concentrate on some of the higher aspects of higher eye movements in this talk.
okay, so all right, shall we close the poll in about 10 seconds? Okay, and let's look at the results for the poll. Okay, wow. So it looks like the close fight between the nystagmus hakao, followed by eye movements egg tarts, and then we have skew as well as the supra and pre-nuclear influences.
Okay, good. So I'm going to put a bit of my bias there. Okay, so nystagmus hakao, okay, it's one of my favorites, so I will start with that. And then second one is actually egg tarts, right? But
yes, egg tarts.
But actually, eye movement basics I've kind of covered in the video that I've given to you all in the on the website. So perhaps we can go on to skew, which is my ultimate favorite. Okay, so let's go to hakao. Okay, so we'll start with this patient of mine. So what do you think? This patient is going to show you a nystagmus, and all we're interested in is when we see nystagmus, is it peripheral or central in nature? So at rest position, there's a little bit of right beating nystagmus, but then suddenly I decide to put on some glasses for her. And then lo and behold, it's much clearer. The nystagmus seems to be worse after I put on these strange looking goggles. I take it away and oh, nystagmus is improved. I've cured her. And then I put on the glasses again and the nystagmus comes back again. I remove the glasses and again, lo and behold, the nystagmus disappears. So we all are familiar with Romberg sign of the limbs, right? So Romberg sign of the limb is basically somebody comes and says, doctor, I'm very, very unsteady. I'm unsteady because something is wrong with my peripheral nerve, something is wrong with my dorsal column. Okay. And I'm okay, but I'm actually unsteady, but right in front of you, I'm okay. But the moment you close my eyes, I'm going to fall because my cerebellum is lost now because it's got no inputs coming from the eyes. Okay. But in a person with cerebellar disease, okay, who comes and says, doctor, I'm unsteady because I've got a cerebellar pathology, but I'm seen to be unsteady right in front of you, even with my eyes open. And of course, when I close my eyes, I fall worse. But even with my eyes open, I'm worse. Why? Because the cerebellum, being the central orchestrator of balance, is already abnormal, right? So it doesn't matter whether the eyes are open or closed. So likewise, in peripheral nystagmus, the cerebellum tries very hard, okay, to suppress the nystagmus. And the only assistance it can get, the only friend that it has, is visual afferents. So it uses vision to suppress the nystagmus. So if you remove vision from the patient, peripheral nystagmus must get worse. So how do you remove peripheral vision? Well, you know, all over the world, ENT doctors make a lot of money. So therefore, they are able to afford $5,000 glasses called the Frenzel glasses. But physicians and neurologists, we don't make that much money. So we have to make do with what we have. So what I've done here is I went to the optometrist and asked him to make the thickest aphakic glasses he can make for me. Okay. With these thick glasses, the patient's vision is degraded, but I can see very well from outside. So without the glasses, she has a nystagmus, but much more obvious with the glasses on, right? Which means that this is actually Romberg sign of the eye. Essentially, with removal of visual fixation, the nystagmus becomes worse, so she becomes more unsteady. So with that, you can add on to the other cues that I've listed below to support your diagnosis that this patient's peripheral nystagmus is indeed peripheral in nature. Remember, in clinical medicine, we always don't rely on one sign, right? We want to use multiple angles to interrogate the question. So for peripheral nystagmus, one of the cues is to look for visual fixation. The others I've listed at the bottom of the slide. Okay, now this is the poor man's Frenzel glasses that I was telling you about. Okay, so for the ophthalmologist, it's quite easy. You just have to persuade your refraction people to just those glasses that they're going to throw away. You just take it on, keep it in next to your slit lamp, and that will be a very valuable, very good tool for you. And if you're not convinced, look at this girl who comes to us with an acute peripheral vestibulopathy, vestibular neuronitis. Look at the nystagmus. So profound it is. The moment I take out the glasses, no nystagmus. Nystagmus? No nystagmus. Nystagmus? No nystagmus. Okay? So that's how we can confirm that's peripheral. Now this man comes to us with severe vertigo and vomiting. Very similar sort of pathology. And again, his nystagmus is mainly horizontal with a bit of rotatory component, with some hints of a peripheral pathology. But the key thing is, there are a few things that were very important in his examination. One of them is whether I put on the glasses or not, the nystagmus was the same. There was no difference in the severity of the nystagmus. And of course, he's got many, many other physical findings in his neurological exam, like what I alluded to earlier. If you just move away from the eyes and examine him, he's got cerebellar signs, he's got numbness on the right side of his body, he's got right facial asymmetry. So he's got all the signs of right lateral medullary syndrome. So clearly this is peripheral nystagmus, but the glasses can help you because there's no change in the amplitude, velocity, and the intensity of the nystagmus, whether with or without the glasses. Okay. Now, the poorest, if you really can't even afford this aphakic glasses, the poorest man's Frenzels is actually the patient's eyelid. Okay. So this man again comes to us with peripheral vestibulopathy. He's got a right beating nystagmus. That is nothing to write home about, right? It's there, but nothing to write home about. But the moment I tell him to close his eyes, again, Romberg sign of the eye, removal of visual fixation. See how intense the nystagmus becomes. So the change in intensity of the nystagmus with the eyes closed, again, helps me confirm that this patient's pathology is peripheral in nature. So, of course, many of us, our eyelids are not thin enough like this gentleman for us to elicit this sign. So, but it's worthwhile trying, you know. Sometimes I try it all the time, but occasionally I'm lucky I get a patient with thin enough eyelids and you can get it. And again, in your ophthalmology consult rooms, it's quite easy to turn off the lights. So again, turning off the lights, reducing the patient's ability to fixate helps you. If the nystagmus gets worse in the darkness, again, suggestive of peripheral pathology. Okay, let's look at this man's nystagmus. And obviously his nystagmus does not change whether you put on glasses or you don't put on glasses. It's a upbeating, continuous nystagmus that doesn't change in any sort of any of the things that I just mentioned to you earlier on. Okay, and of course, again, if you forget about the nystagmus and go on and examine him, okay, you find that he has got other signs to tell you that definitely this is not peripheral pathology. This is central nervous system pathology. Basically, when he looks to the right, there's no problem. When he looks to the left, the right eye is not moving. So he's got a right internuclear ophthalmoplegia. So therefore, this straight away tells you the guilt by association principle. The fact that the nystagmus is associated with other central nervous system signs makes it unequivocally a central nystagmus. Okay, now the next question is, why in the world is this patient who's got a medial longitudinal fasciculus lesion with INO having an upbeat nystagmus? Why an upbeat nystagmus? How do you explain upbeat nystagmus? Again, the pathophysiology is actually quite beautiful, and we shouldn't be paganistic and memorize things. We should be spiritual and enjoy the beauty of upbeat nystagmus. And I'm going to help you explain this, okay? So firstly, a question for you, okay? Now, while you're trying to answer this question, I see many of you are vigorously shaking your head like this, right? Up and down. Okay, while vigorously shaking your head up and down, your eyes are still fixated on this patient. This person, sorry, actually he's also a patient. Okay, so a lot of pathological conditions in him. So you're looking at him while you're shaking the head, right? So the ability to do that is because you have a vestibular ocular reflex. Okay, your semicircular canals in the inner ears, okay, are picking up the signals as you're moving the head up and down and sending the signals up. How do they send it up? There's one major escalator in your brainstem, and the major escalator is your medial longitudinal fasciculus. So all these inputs are going up the medial longitudinal fasciculus to your third and fourth nerve. So up and down movement, no issues at all. Okay. Now this up and down movements, okay, up and down movement, just like horizontal movements, no issues at all. But there is one other aspect that you mustn't forget when it comes to up and down movements. There is an all-pervading force. Okay, and it's not Star Wars force. It is just gravitational force. Okay, gravitational force is all pervading, it's always there. Okay, so if it's always there, you have an up and down movement that's predicated on your head movement. But at the same time, in the background, there's always gravity acting all the time, always pushing down all the time, since the beginning of time, right? Since the beginning of evolution, from the lowest organisms all the way up, there's always gravity. So there must be some way to counter gravity. So what is it that we counter so well? The organ that picks up the stimulation is your otoliths organ, right? The right side and the left side. This otoliths organs will then send up a signal. Okay, they have an additional component. Okay, we call this a central ventral tegmental tract. This is a particular tract that travels from your vestibular nucleus, and the inputs are coming from the otoliths. Okay, they're traveling up the pons, crosses in the mid pons, okay, and travels up the midbrain and arches up and touches the fourth and the third nucleus. So this central ventral tegmental tract is continuously tonically firing to counter the balance of counterbalance the effect of gravity, counterbalance the effect of gravity, so that the eyeballs are not pushed down all the time. Now, imagine there is a lesion in the central ventral tegmental tract. Okay, a lesion. Okay, and the medial longitudinal fasciculus is nearby also, right? So if there's a lesion close to the medial longitudinal fasciculus and there's a lesion by chance affects the central ventral tegmental tract, let's say what happens. The patient's gravity is always acting, and suddenly this force that is counterbalancing it, counterbalancing gravity is gone, right? So what happens to the eyeballs? They're going to slowly drift down according to gravity, right? But we are conscious patients, we have reflex saccades. So what do? Reflexly, we bring it up, boom. And then gravity is acting again, brings it down. And then the reflex saccade, boom. And then gravity brings it down, boom. Gravity brings it down, boom. Gravity brings it down, boom. What is this? Upbeat nystagmus, right? So that's all there is to it. So when we saw this patient with an internuclear ophthalmoplegia from an MLF lesion, we said this patient must have an additional lesion involving the CVT somewhere along this way. Okay, so we told the radiologist there must be something else. Please go and look for it. Okay, and of course, we told him exactly where to look for, because there's this one of our good colleagues from France has written this beautiful paper. I think Dan's previous colleague, and Dan was actually very instrumental in the original work on this. So we must give great credit to Dan and his team. So they have tried to identify the pathway of CVTT in humans. Okay, and they believe that in the mid pons, it's somewhere around here. So with this, we told the radiologist, hey, please go and look at it. And true enough, they found another spot, just above the medial longitudinal fasciculus. Remember, the patient had a lesion in the medial longitudinal fasciculus. In the next cut, there is another small dot exactly where Dan and his colleagues previously had published where the CVTT is. Okay, so we said this is the reason why this patient has upbeat nystagmus. So this patient has got upbeat nystagmus and internuclear ophthalmoplegia because he's got a contiguous lesion in the pons. Okay, so that's it for Hagao. So, Ruben, how are we doing for time? Do we have time for skew deviation?
Yes, definitely, Prof.
Okay,
So we
skew
can go on to the next one, which
Okay.
is
Skew
skew
deviation,
deviation.
I'm going to use the same patient. So I think one of the reasons we knew straight away, and many of you saw this patient, straight away you knew that his upbeat nystagmus must be central because in addition, he's got skew, right? What is skew? Well, one eye up, one eye down, right? That's skew, vertical deviation of the eye. Okay, so this guy has got vertical deviation of the eye, so he must have a skew deviation. So now we have another problem, right? We said MLF, we understand why I know, right? We also said, okay, he's got upbeat nystagmus, okay, skew. Then how do we explain skew? Okay, so again, skew it's so, the pathophysiology is so beautiful. I tell you, when you understand it, you get goosebumps, okay? But somehow the textbook make it very paganistic and ask you to memorize things. So you work with me, okay? So now you just focus on what I'm going to show you in, what I'm going to show you. You look at my, look at me, okay? And this diagram, we already alluded to it, right? So we said the otoliths inputs are going up to the third and the fourth, right? So the otoliths are picking up the signal. Now we have to think about our evolutionary paths. Okay, so now if you look at my face now, if you look at the video and look at my face. Now, we are frontal-eyed animals. We have horizontal VOR, okay? And we talked about vertical VOR just now. But we also have another VOR, which is basically torsional VOR, right? So when I turn my head to the left, what happens? My right eye extorts, my left eye intorts, right? When I turn my head this way, my right eye intorts and my left eye extorts, right? Basically, that's what we need to do, right? But that's all we need to do because our eyes are in front. But we mustn't forget that we didn't just appear in this planet like that, right? We have evolutionary ancestors and evolutionary brothers and sisters, okay, mammals, which have eyes on the side. So let's look at one of our favorite animals, rabbit, right? I know Jing's favorite animal, one of the favorite animals is rabbit. She has a rabbit in the house. Okay, so rabbits have eyes on the side. Okay, so imagine now I'm a rabbit, right? I'm running away from the fox. Okay, as I'm running and I come to a slope. Okay, so my head tilts to the left. Let's say it tilts to the left. Now, when my head tilts to the left, my right eye is going to go up and left eye is going to go down. And suddenly the horizon will look different and I get confused and I may start tumbling, and then before I know it, I'll be eaten by the fox. So what about having a reflex that allows my eye, my right eye, my head tilts to this side, my right eye comes down, my left eye goes up. My right eye comes down, my left eye goes up, right? Okay, now, so basically for us frontal eye animals, when we tilt our head to the left, our right eye extorts, a left eye intorts, right? So now if we are a rabbit, if I'm a rabbit, okay, the same thing must happen. When I turn my head to the left, my left eye must intort, my right eye must extort, right? But in addition, this eye will go up and this eye will come down, correct? Because you see, my head is like this, right? My eyes are stuck. So in addition, for the rabbit, the eyes must go up and down, Now, this reflex is obviously has to be modified for us because if the eyes are up, whenever I turn my head left and right, I don't want my eye to go up and down, right? So I've suppressed it and I've only kept the torsional movements. But this is a suppressed reflex. And we know in neurology, throughout neuroscience, all our primitive atavistic phylogenetically all reflexes are suppressed in humans, right? And when diseased, they appear again. You may see it in a child within the first year of the life, but it will appear again, okay? If you don't believe me, you can look at this patient, okay? We all have a prominent grass reflex and a prominent pout reflex when we were babies. But after the age of 1, most of us have lost the grass reflex and the pout reflex, right? But when we develop disease, like this gentleman developed a disorder called hand, which causes severe neurodegeneration, right? And you will see that the moment I bring my hands in, he will grasp for no explainable reasons. He will grasp onto my arms and won't let go. In fact, I can lift him up just by holding on to him like that. And when I put my fingers close to his mouth, he will start going towards it, rooting reflex, and he will start pouting, just like a baby. Now, why? He's a 70-plus-year-old man. That's because his phylogenetic all pathways are reappearing when there is pathology. The same thing happens in skew. Okay, I'll just show you very quickly what happens. You see how he's gripping, going for my hand, and he'll hold on to my hand as if his life depends on it. And in a few moments, you will show that his lips are going towards my finger. He will start going towards it and he'll start kissing it like as if he's going to do a pout reflex. So this kind of things happen. It's going to happen again in the brainstem when there's brainstem pathology. So now the way we have to think about it is that if we have disease in the brainstem, we become rabbits again. We become rabbits again. So imagine I have a problem. I'm a rabbit and I've got a problem. Okay, so let's work. You work with me. Okay. Now my eyes are on the side, right? Okay. So now I have a pathology on the brainstem in the utricular pathways. And the utricular pathways, remember, they're traveling up the MLF all the way to the third and fourth. This pathway is disrupted. Okay, it's disrupted. So now remember when I was a rabbit, right? I am a rabbit now. I'm turning my head to the left. What happens? My right eye comes down, left eye goes up, left eye intorts, right eye extorts. Correct? Okay, now I do the other way now. You can work with me. Okay, turn this way now. My right eye goes up, left eye comes down, right eye extorts, left eye intorts. Correct? Okay, so now if I damage the pathways on one side, okay, the brain suddenly is going to think, oh my God, the head is tilting to the right because this side is gone, right? So this side, no stimulus. So the brain is going to think the head is tilting to the right. The rabbit's head is tilting to the right. So the brain is going to react as if the head is tilting to the right. Remember, if the head tilting to the right, what happens? Right eye will go up, left eye will come down, right eye will intort, left eye will extort. Skew deviation. That's all there is to skew deviation, right? The head is tilted to the right, right? So imagine the head is tilted to the right. Imagine the head is tilted to the right. So the brain will make the eyes move as if the head is tilted to the right. Okay, so if you don't believe me, let's work the other way around. Okay, now I've got a lesion on the other side of the brain. Okay, this side, the inputs are not going. This side is working over hard, right? Working too hard. So what's going to happen? The brain is going to think my head is tilted to the left, but my head is still steady. But as if it's going to turn, the brain is thinking that my head is tilted to the left. If my head is tilted to the left, I'm a rabbit, remember? So what will happen to my eyes? My left eye will go up, my right eye will come down, my left eye will intort, my right eye will extort, right? Exactly what happens in skew deviation. Now, the only thing I haven't explained to you is the head tilt, okay? Very simple. Remember, just now, my brain thinks that my head is tilting to the right, but my head is still steady, you know, but my eyes are moving like this. So what will I think? Oh my God, the whole world is upside down now. I'm going to think that the horizon, the vertical, the visual vertical has been tilted to the right. So what do? I turn my head. Always got sound effects. Huh? All eye movements got sound effects. Huh? So my head will to the opposite side. So therefore, your right eye will be up, left eye will be down, right eye will be intorted, left eye will be extorted, and your head will tilt to the left, the complete OTR. And that's all there is to skew deviation. Now, the final bit, skew deviation versus superior oblique. First rule, forget about the eye and look at the rest of the patient, okay? Often it's much easier. Like all our patients I showed you just now, they have so many other systemic signs that you don't have to worry whether this is skew or not skew because they have other signs, right? INO, he's got weakness, he's got Babinski, he's got so many other signs, okay? But I would think that sometimes it's still useful to get all the signs, right? So in this patient, actually, as a matter of fact, this patient that I was telling you, this patient, when I looked at his higher eye with a direct ophthalmoscope, what do I focus on? Very simple. You know, nowadays, you have to wear all these goggles, still have to get used to ophthalmoscope. So with the goggles, we still manage to just see only one thing you need to see. Where is the disc? And quickly decide where is the disc in relation. Just look at the higher eye. No need to worry about the lower eye. The higher eye, where is the disc in relation to the macula? Okay, in this patient, the disc was lower than the macula. Remember, superior oblique is superior. So the disc will go higher. In this case, the disc was lower than the macula. So again, another point to tell us that this patient has got skew deviation. And as if this is not enough, our good friend from Canada, Dr. Wong, published this beautiful paper that says that skew deviation is related to gravity, right? Because these otoliths inputs are coming from the gravitational force. So what if I take away gravity by getting the patient to lie down? Okay, so in this case, what I did was took the top pictures when the patient is sitting up. The patient is sitting up. Look at the degree of hyperdeviation. Okay, then we get the patient to lie down and took a picture again. Of course, you can do the cover uncover test. And if you see a dramatic difference, the point is dramatic difference. If you see a dramatic difference, then you're more consistent with skew deviation because the gravitational input is negated when the patient is lying supine. But if it's a superior oblique lesion, doesn't matter whether the patient is lying down or sitting up, it will be the same. So this is an additional tool. Now, none of the things that I talked about in isolation are absolute. But if you put everything together, that's what clinical medicine is all about, right? We put everything together and we make a decision. Thank you. Okay, so how are we doing for time? We must be done by
Prof,
now.
we can do one more short dim sum if that's possible, and then after that,
Really,
we'll go to the Q&A.
Okay. Let me think which is the short one. Head thrust sign. Okay, shall I do the head thrust sign?
Yeah, sure, definitely.
Okay. So head thrust sign is the shortest, I think. Eye movements, I think it's kind of redundant because it's kind of, you can look it up in the video. Okay, I'll do the head thrust sign. So the basis of bedside VOR testing. Okay, so now what am I doing for this woman? I am moving the head left and right, right? So many of us think that we are doing the VOR testing for this patient. Now, I would like to challenge you and ask whether is it truly VOR? Because you see, most of us are biased into learning that the VOR response in a comatose patient in ICU, it's true VOR. But she's an alert patient, right? So when you're an alert patient and if I hold my head like this and I turn my head left and right, I ask them to look straight ahead. Of course, it is VOR, vestibular ocular reflex acting. But I'm conscious, Because I'm conscious, I can also track, correct? If you just think about it, if what is tracking, what is smooth pursuit, it is like this, right? Move left, move right. Move left, move right. That's smooth pursuit, right? And it requires a conscious patient. What if I fix my finger and I just move my head? That's also smooth pursuit. So in other words, when we are doing the slow head movement in a conscious patient, asking them to fixate on an object, we are not only testing VOR, but at the same time, there's a redundant system pursuit. So both of them are mixed up. So depending on the alertness of the patient, both of them are there. So therefore we have a problem. We cannot test the integrity of the vestibular system in a conscious patient by just shaking the head left and right. One thing you can do, you can knock her on the head, make her unconscious. She can't see anymore, right? Then when you do like this and the eyes are not moving, then you can say VOR, because there's no conscious person behind to direct the tracking. Then it's okay. But in a conscious patient, you cannot use slow head movements. So that is the basis of this genius of Dr. Halmagi about 20 years ago. He thought about the head thrust sign, right? So basically, when can you take pursuit out of the equation? Short of knocking the patient on the head and making him unconscious, which is unethical. How can you take pursuit out of the equation? Okay, let me just show you, okay? So look at my finger. I'm doing pursuit, right? Now, when can pursuit become redundant? If I move my finger so fast, now my pursuit is replaced by saccades, because pursuit can only track if the object is slow. But if you suddenly move the object very fast, you can't track. Pursuit dies and saccades come and take over the play. So instead of moving the finger fast, Dr. Halmagi, being the genius, he said, why don't I move the head fast? And that's the basis of the head thrust. So this is what we are doing for this lady. So first we move the head left and right. VOR is perfect, right? But of course it could be pursuit. But then when I do the fast movement to the right, no problem. But to the left, Now, many of you know that straight away when I move the head to the left, a head thrust to the left is suggestive of abnormality. The head thrust is positive, meaning that when I move my head to the left, the eyes follow. Maybe I'll just stop it for a while. If you just look at my screen, look at my face. So basically when I'm looking at you, when I turn my head left and right, I'm still looking at you, right? But if I turn my head fast and my eyes tend to follow my head, and then subsequently the eyes come back to you, that is a positive head thrust. Okay. Now, the problem with this test is that many patients are not interested in your object. So you ask them to look at your nose, look at your thing, look at all kind of things. They will be looking all over. Okay. So a lot of times head thrust can be positive transiently in a patient who's inattentive. But if it's positive on one side and consistently positive, no matter how many times you twist the head, is always positive, then you get it. One of the things as a beginner when you start doing this test is that, you know, I always call this, I think during COVID times it's a bit difficult. During my clubbing days, I used to hang out with all these good-looking hot guys. So I had to learn the skill that every time somebody looks at me from far, a lady is looking at me from far, I have to be sure she's looking at me and not looking at my hot friends, because my friends are all very hot. So if they're looking at me and I think that she's looking at me and I go and approach her, I'm in trouble, right? So this ability for you to know when somebody is looking at you and not looking at somebody else, that is very important. So if I'm looking at your screen now, you know I'm looking at you, right? For sure. But if I look slightly away, it doesn't look like I'm looking at you. Okay, this is a human, of course, it's a useful skill in clubbing. But Also a useful skill in head thrust side. When you see that the patient is not looking at you anymore, looking at something else, then the head thrust is positive. Okay, so look out for that. Okay, so let's try again. So when I move the head slowly, no problems. When I'm moving the head to the right, she is still looking at me. When I do it fast, to the right, she's looking at me. She's looking at me. Now, she's looking at my hot friend. She's looking away. She's looking at somebody else. Correct? So this, okay, if I were to mimic a head thrust for you, okay, let's say my right head thrust is abnormal. So left side positive, sorry, left side normal, normal, normal. Now, positive head thrust will be, my eyes will follow the head, then subsequently there will be a catch-up saccade. There will be a catch-up saccade. Look up for the catch-up saccade, okay? So that is how you pick it up. So now that you know how to do it, you can, let me ask you this question. Which side is positive for this man? Okay, remember the clubbing rule. So the eyes must see your eyes. The gaze must fix it, okay? So he's still looking at you? He's still looking at you? Still looking at you? He's not looking at you. He's not looking at you. And then he does the catch up. Okay, so now you've gotten the hint of it. Okay, let me try one more time. Now, this is another skill that I want to impart on, especially if you're starting to do this test. Now, it's good to start from the center to the left. Center to the left. But some of these patients with vestibular pathology, they have an nystagmus going on, right? And sometimes the nystagmus can be tricky, right? So one easy way to, when you're starting off, learn to do both ways, okay? So from the center to the left for the left side, center to the right for the right side, but you can also start from the right back to the center, right back to the center, and then you're testing the left here, and then from the left back to the center, left back to the center, and you're testing the right here. Now, most of us are much more, it's that much easier to know whether the person is looking at you straight on when the eyes come back to the center. So this particular way of doing it is an easier way when you first start off doing. So especially because there is a learning curve to it. So this is a conventional way. Okay, just see whether this is a tricky one because it's less obvious. See whether you all can pick the diagnosis. Remember, if she's not looking at you, that means it's positive. She's looking at you, not looking at you. Looking at you, not looking at you. Now I'm going to show you the other way of doing it, which is start from the side and come back to the center. Okay, I'm going to start, this is still the same way. So I'm going to start from the center. Okay. You saw that? So in other words, I'm starting from the left and coming back to the center, right? So her right head thrust is positive. So of course you can do it this way. So the second part of the video, I don't know whether you've managed to catch it. I'm starting from the left. Okay, I'm starting from the left and coming back to the center. And again, you will get that feeling, she's not looking at you. And just remember, the direction that you're turning your head to is the ear that you're testing. Okay, the direction that you're turning your head to is the ear that you're testing. And if the eyes lose your gaze, she looks like she's looking at somebody else, it's positive. Okay, last one. Which side is abnormal? See whether you can guess it. The camera. Okay, let's try again. Very good. I think most of you got it. Bilateral positive. Very tricky. Bilaterally positive. This guy has got a very unusual disease which affects both vestibular systems. So bilaterally, his head is stuck. Eyes are stuck to the head. Turn to the head, follow the eyes, and then he does a catch up. And then turn to the other side. Eyes are stuck to the head, and then he does a catch up. So bilaterally positive. Not common, but once you get the knack of it, you'll pick it up. With that, I better stop. Thank you.
Thanks, Dr. Uma, for your very, very interesting talks. We really learned a lot from these 3 talks. Now we've come to almost the last part of today's seminar. So we would like to invite all our panelists to turn on their cameras, as well as to engage in any discussion of any of the lectures that they actually found interesting, or if there are any questions or any pertinent points they would like to bring up. I'll hand the time now over to Dr. Lu and Dr. Sharon, and they will moderate this session for us.
Thank you, Uma. That was wonderful. So do we have any questions from panelists?
a question to Prof. Uma. Wonderful talk, as always, Uma. It's a pleasure and it's good fun, and that's the best way to remember things. Can we conclude that any vertical nystagmus is by essence central?
Yes, I think the way to look at it is that for peripheral pathology to cause central nystagmus, then you have to be a very sinister ENT doctor who goes into 1 year, damage the posterior canal on this side, damage the posterior canal on the other side, then the anterior canals on both sides are active, so they'll push the eyes in the right direction, and then you get a peripheral nystagmus, right? So and likewise, if you do a surgery that affects only both anterior semicircular canals on both sides, okay, equally, then you can get a vertical nystagmus for peripheral pathology. So therefore, almost all diseases, they affect one ear or the other, and they affect they don't preferentially affect one semicircular canal, they affect all three. Okay, but having said that, some of the audience members may be straight away thinking in posterior BPPV. Okay, we have a beautiful example of an upbeating nystagmus, right? But we don't call it upbeating nystagmus. We call it paroxysmal positional nystagmus, where patient is normal at rest. Okay, it's not counted as what we are talking about. Normal at rest. We put the head down, and when we put the head down, what canal are we stimulating? We are stimulating the posterior canal because the otoliths are stuck in the posterior canal. And the patient's nystagmus is beating, actually from the point of view of the patient's head, is beating towards the eyebrow. Correct? So it is, in a way, a vertical nystagmus, but we don't call it a vertical nystagmus because it only occurs during stimulation of 1 ear in a certain position. But otherwise, all vertical nystagmus. But having said that, there may be some exceptions that I'm not familiar with, but as a general rule, I think when we see vertical nystagmus, it's central. I must really thank you for the excellent papers that you guys wrote on central nystagmus and downbeat, upbeat. In fact, prior to these papers, I was quite lost about the whole thing. So I must really thank you.
Many years
You've
ago.
been too humble about it because you're
Many years ago.
the pioneer of this work. We're happy to have you in Singapore, actually.
Likewise, Uma.
Okay, if there's no further comments, then we'll wrap up, call this session to a close, and thank all our speakers and our panelists for a wonderful session, and our audience as well. And hopefully we'll see you next Tuesday for continuation of this course. Thank you very much, and goodbye, and have a good weekend.